Good morning. Today we are going to discuss the subject of chest pain. Now my experience is like that most of the GPs, when the patient comes for chest pain, of course all the patients who come for chest pain also, the first thing that they have got some heart problem. The GPs usually, when they hear the chest pain, they take out their blood pressure instrument, they record the blood pressure, they take out their stethoscope, they hear the chest. In my opinion, this is all wrong. This is the medicine which was taught to you in the hospital, in the college, for hospital practice. You are not doing hospital practice. You are doing general practice. So, in general practice, all this blood pressure instrument, all the stethoscope, this patient of chest pain, okay. Maybe if the patient complains of palpitations and not chest pain, okay, you can use your stethoscope. Because if you see the tachycardia, maybe supraventricular tachycardia in a young woman, or in a young woman you listen to the heart and atrial fibrillation, irregular rhythm. But as far as the chest pain is concerned, most important is history taking and the way in which you take the history. Look at the patient, look at his face, look at his actions, look at the way in which he points his finger or hand, and then examine, palpate, and you get the diagnosis. Finish. The chest pain could be due to anything which is in the chest, for example, skin, subcutaneous tissue, muscle, breast, ribs and chondri, xiphoid process, neck and shoulders. The pain could come from any of this and it could be very severe. The severity will not give you the diagnosis. In the sense that, for example, the patient complains of pain. No, wrong.
Starting.
Stop. Here is a patient who complains of pain in the left upper chest and the shoulder. Now I must tell you, every year or two I show these patients on the stage. Last year I brought this woman, 50-year-old woman. She got severe pain here in the chest and here. Severe pain. So much so she was admitted in the hospital, 5 o'clock in the evening. In the 5 o'clock in the evening she was admitted in a private hospital. And they did an X-ray, they did an ECG, they did a 2D echo. Nothing came out. They did a CT scan, they did an MRI of the spine, and later on at night they did CT angiography. And all these investigations were normal in the whole night. And the husband was looking at the bill. He'd already spent 45,000 rupees. So in the morning at 6:30, 6 o'clock, he took discharge against medical advice. Because she was suffering so much from pain and no diagnosis could be made. He was my old patient. And I started my practice in the morning at 6:30. So he straight came at 6:30. And as soon as he came, I made a 1-minute diagnosis. These people had not examined her and removed her clothes, and not even removed her clothes and examined this area. Examine for what? Yes, video please. Examine, you look for vesicles. Yes, these vesicles. I took my lady assistant, removed the blouse, and on the shoulder we found, and I made a diagnosis. This was a patient with herpes zoster. Herpes zoster. This herpes zoster, he developed this. Now in the books they mention that this comes after 1 day, 2 days. But in private practice, my experience is that some pimples like that may appear early. The full picture of herpes zoster takes about 3-4 days. And the moment you see this, that is the time when you start herperex tablets. Herperex tablets work only when you start very early, because the pain of herpes zoster is very severe. Not only that, if you give the tablets later on, these patients, after they recover, they develop neuralgia, and the post-herpetic neuralgia is more severe in patients who did not take a course of herperex. Next. Now, stop. Here is a patient who complains of pain there in the front, and the pain is tolerable in the sense she is rubbing it and showing that there is pain. And this type of pain shown like this with 3 fingers like that, paravertebral, the commonest cause is chondritis. Chondritis is cold of this vertebra, the front of the vertebra, which are chondri. They have got cold. Tits syndrome is the name. It's a very common disease, very common illness, not mentioned in the textbooks. And yet in private practice we see it so often. And you were to only pass time, give some pain relieving tablets, some creams, and this chondritis. Now, here is another cause of such pain is, here is a patient, I shaved off the hair to show you this swelling. This little swelling is a sebaceous cyst. Sebaceous cyst, small sebaceous cyst. Now, most of the people have got in their body, under the skin, some sebaceous cyst, some fibroma, some neurofibroma. And if you got this neurofibroma here, then that is the pain which the patient goes on complaining of. And if you can localize that neurofibroma and press it, patient will get pain. And then you have to explain to the patient that this pain is coming from this neurofibroma. If you want, you can get it removed. If you don't want, leave it alone. Don't touch that area. Don't touch that area very often. Next. Stop. Breast. Male breast. The pain is on the left chest. Press the male breast. Because gynecomastia, pain, side effect of number of drugs, starting from Lasix, and there is a lot of drugs which can cause pain in the breast. So when you press like that, and the patient has got pain, look for the drugs and omit the drugs. Continue. If it is a female patient, continue. Then of course you have to do proper palpation of the breast look for any tumor, any cyst, any mass, stop. Then there is a pectoralis muscle. If you tell the patient to press like that, and then you press this area of pectoralis muscle. If it is very tender, then this patient has ruptured some muscle fibers during lifting some weight. You have to ask the history. In the previous 24 hours, did he lift any furniture? Did he lift any weight? See, these muscles are made like clothes. The muscles are made of fibers, and these fibers can rupture. And when the fibers rupture, you can get severe pain. This is the cause of chest pain. Continue. And now local pain. Stop. If the patient has got a local pain shown with a finger, and if it is very tender, the cause is cuff fracture, often seen in patients who have got COPD, smokers, elderly smokers. During a violent cough, they'll crack the rib. Similarly, you can see that local pain in one area or multiple areas in osteomalacia, women with severe vitamin D deficiency, which has now disappeared. Now everybody takes vitamin D, everybody is taking vitamin D. But in olden days it was so common to see a woman coming with body ache and weakness and such local severe pains in the ribs due to cuff fractures. And you only diagnosis you make is you make the patient sit down and tell her to stand up. She finds difficulty in standing up. That is osteomalacic myopathy. Then all you give is vitamin D and the patient will recover. But if you see this local pain in multiple areas in elderly people, elderly males, the first diagnosis is secondary deposits from cancer, prostate cancer. So remember that elderly people, you have to screen off prostate cancer by doing of course blood PSA and nuclear studies, which will show that X-rays will not show anything in such patients. Yes, continue. Now, if the patient shows pain there, that is again chondritis. That's the area, the second, third, fourth costal cartilages. You get cold and you get pain. Pain is not severe, patient shows with a finger but can rub there, and rubbing slightly increases the pain. There is no special treatment, but it is very common. Next. Now the same thing here, same thing in the epigastrium. In the epigastrium you got xiphoid process. The xiphoid process is also chondri, it's not bone. So if you get chondritis in xiphoid process, and then when you examine the xiphoid is tender, that is chondritis of the xiphoid process. Not to be mixed up with hyperacidity. Hyperacidity is different, burning pain, and it's not in this chondri. Yes, next. Pain in the shoulder. Suppose patient talks about pain in the shoulder. Shoulder pain means you have to look at the, if it is on the left side, left lung base, left pleura, and of course heart pain. Heart pain can be in the shoulder. Yes, next. Next. So if there is an acute pain in the lower chest and shoulder, right side, and the patient has got fever. In olden days, I'm talking about 20 years back, 30 years back, it was a spot diagnosis, 1 minute diagnosis. This patient has got pain in the right lower chest, he can't sleep at night on that side, it's so tender, and he also has got pain in the shoulder, and he also has got fever. The diagnosis was amoebic liver abscess of the superior surface of the liver. Condition which has more or less disappeared, 90% has disappeared, thanks to Metrogyl-like drugs in the market. Metrogyl, Flagyl has wiped off amoebiasis. We no more see such patients, which we used to see very often in private practice. So when the patient says he has got chest pain, he should be told to show where is the pain, and which he shows with the finger or the hand. And if you saw the first slide, the patient is showing the pain, but he doesn't want you to touch that area. Which is that pain in the chest where you get so severe that patient doesn't like you even touching that area? Herpes. Herpes. Remove the clothes, look for a few vesicles. That patient will show rash of herpes zoster within 2-3 days. Now show the video that a heart pain of myocardial infarction or angina, the patient shows like this. Either he puts a hand there, this is the area where he gets. Next, 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 continue, next. This is the second area which can be shown as a heart pain. Next, this is the another area of heart pain where you can get straight pain in the epigastrium, severe pain in the epigastrium. This is another area where precordium and the left arm, precordium and the left arm. Next, show next. Or the patient may show like this, the site of pain with the wrist, clenched wrist. Next. So, coming again to the chest pain, the important thing is the duration. And number 2, is it sudden pain? Sudden pain build up, how it builds up? Is it an acute pain or a chronic pain? Now, when I say the chest pain is sudden, when I say sudden, I mean like in the past we discussed subarachnoid hemorrhage in the brain, where the patient's headache is sudden. He knows the moment it started. So acute is different. Acute, yes, it's acute, very sudden, very sudden. This suddenness is diagnostic of pulmonary embolism, pneumothorax, rupture of the aneurysm. Pulmonary embolism is a condition where the blood clot from the leg comes in the chest. And this occurs only in those patients who are lying down in the bed for a long time due to operation or an illness. Old people, and the leg gets swollen, no attention is given. One day the blood clot goes in the lung suddenly and patient gets pain. He can die also. Second condition is pneumothorax. Pneumothorax can occur at any age, young age, middle age. And most of the time the cause is again like subarachnoid hemorrhage. There the patient has got small aneurysm, whole lifetime it may not rupture. Here the lung, one of the lung has got something like a small balloon here, bulging. And this balloon might one day rupture. And the day it ruptures, it will produce a severe pain on that side and difficulty in breathing. So severe pain on one side, suddenly, occurring suddenly, with difficulty in breathing is pneumothorax. That patient is should be shifted to the hospital to remove the air from the chest. There is a third condition, rupture of the aneurysm. We in our country we are seeing it less often because you don't see elderly patients. This is more common, elderly, 80, 90, 100. If such a patient gets a chest pain which looks like myocardial infarction but collapses, one of the causes could be ruptured aneurysm, aortic aneurysm. Pain can start and then build up. See, the myocardial infarction pain can come at 12 o'clock at night and he gets this thing, he is sweating, vomiting, then again it dulls down. Again after 1 or 2 hours it starts, again it increases. That is the story of myocardial infarction. So pain can be acute, the pain can be chronic pain is a different diagnosis. I was talked about the cough fracture, osteomalacia we discussed, old males, multiple ribs, cancer of the prostate. Moment there is a chest pain on deep breathing on one side, left or right, often it's accompanied by fever, cough and dyspnea. The commonest cause is pneumonia or pleurisy. Pneumonia or pleurisy. X-ray test or sonography will show. And then of course the commonest in a particular population. The public is afraid of ischemic heart disease, IHD, and the doctors also are afraid of it. Yes, of course, you should be. But what I want to tell you is this, that ischemic heart disease, which you see in private practice, there are 3 types: silent, angina, myocardial infarction. Most of you GPs will be having patients who have got silent ischemic heart disease. They don't go to specialists. It is you who are going to pick them up. How do you pick up a silent coronary artery disease where the vessels are blocked? Suspicion. Suspicion in a middle-aged or elderly person who's got some strong family history. In the family, either father, mother or brother, sister or uncle, maternal uncle, paternal uncle had a heart problem, and who is a smoker, a drunkard, doesn't do exercise, pot belly. Such a patient, especially diabetes with hypertension. So often diabetes is very well controlled, blood pressure is not well controlled. But if you have in your practice any patient who's got diabetes more than 10 years duration and hypertension, many of them go together, suspect ischemic heart disease. Suspect and do investigations. You will be surprised when you will find some of them with a stress test positive, or if you do further investigation of stress 2D echocardiography positive, or nuclear studies. When you do nuclear studies, you find that some vessels are blocked, or CT angiography. Today CT angiography has become an outpatient investigation for GPs. The patient is not to be admitted in the hospital, and the patient to the outpatient. CT angiography shows there are 2 blocks or 3 blocks. The patient has got ischemic heart disease, and you should start the treatment that time before he gets one day an attack of myocardial infarction. So silent ischemic heart disease should be picked up by general practitioners. suspected in such patients who have no symptoms. But you have to explain to them that if you don't take the treatment, don't start aspirin that time, don't start cholesterol lowering drugs that time, then there are more chances they'll develop one day an attack of myocardial infarction. The second type of heart pain is called angina. Angina pectoris. Angina pectoris is a common condition, but unfortunately these patients don't go to specialists. Because they don't go to specialists, it is your responsibility to diagnose, pick up these patients of angina. Why don't they go to specialists? Why? Because the pain is not severe. And secondly, second point, that whatever pain comes, it disappears within 5 minutes. Then why should he go to a specialist? That is how the patient thinks. But I am telling you that if patient gets a pain on exertion, on doing some exertion, climbing steps, running to catch a bus, running to catch a train, going on a steps on the train in a hurry to catch the train, or the patient in the morning after breakfast. This is quite common in the morning. After breakfast, carries a bag in his hand and is running, going fast to catch the bus. That is the time when these heart pains come. And this heart pain can come at any area with any method which I showed you some time back. A patient might show here, 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 and sometimes in the neck, sometimes in the jaw. These pains come, but as soon as the patient stops, the pain disappears. As soon as the pain stops, the pain disappears. So the patient doesn't give much importance to this. But one day he just tell his GP that something comes like that and then goes away. Why? What is it? He wants to know what is it. That is angina. These patients have normal ECG, remember that. Normal resting ECG. Only when you do a exercise ECG, exercise 2D echocardiography, stress 2D echocardiography, or stress nuclear studies, you will pick up that they have got angina. And nowadays you can confirm it with CT angiography. Coming to myocardial infarction, it's a hospital illness. You are not supposed to touch this patient once you diagnose them. Once you diagnose myocardial infarction, your duty is to see that they as early as possible in an ICU, where of course troponins will be done, D-dimer blood test will be done, CT angio will be done. These patients should be as early as possible in the ICU so that they can be given proper drugs to dissolve the clots, and they may need a stent. So when will you suspect, and so fast you have to move the patient of myocardial infarction? When such a patient with this background which I told you earlier, such a patient one day, he is normal, absolutely normal. He has gone for a party, he had drinks, he had heavy dinner, but he comes home at night and he gets what? Some complaint which he can't, not pain, it's not a pain, it's that some discomfort, but he shows like this, or shows like this. And this discomfort is accompanied, most important, by heavy sweating. Heavy sweating. The whole body becomes wet. So patient is surprised that how with this much sweating has come out of proportion. And there is usually a vomit. The patient vomits. There may be severe nausea. There is often vomit. This combination of a slight discomfort, but good enough with it. Severe sweating and vomiting, the patient has to be shifted to ICU as early as possible. In private practice, there's some patient refuse to go, and they force you to treat. You can do the blood test of the enzymes, troponin, and then in private practice you've got CT angio now available. CT angio is an outdoor investigation. Send the patient, the CT angio will show blocks. The moment it shows blocks, the patient has got myocardial infarction. He has to be shifted to the hospital. Remember that in ischemic heart disease, there need not be any pain, neither is there any burning, but many people use the word gas. They get gas. Gas means some discomfort which they cannot describe. That is why they use the word gas. Whenever a patient comes for chest pain, what position increases and what position decreases can make a spot diagnosis. An 80 years old lady at night got a severe pain in the chest and the back. Severe. So naturally the GP first wanted to exclude, thought of myocardial infarction. ECG shows TF changes, ST changes. No typical ST elevation. And he said you should get admitted. With myocardial infarction, you need a stent, etc. This lady whole night, she passed. She said, no, I don't want to go to the hospital. I'll go to my doctor. And early in the morning, 7 o'clock she came to me. And what I noticed was, every time she was sitting with a bending forward like that. Moment I told her to lie down straight to examine, no, doctor, no. Severe pain in the back. So severe pain in the back, which is also felt in the front, like a myocardial infarction. But when the patient feels better while sitting forward, it's a spot diagnosis that there is one of the vertebra has collapsed due to osteoporosis, severe osteoporosis. So, if you see this patient where the pain becomes less with this position, spot diagnosis of severe collapse of the vertebrae. In this patient's vertebrae, it doesn't need so much emergency. There are people who try to do interventional treatment, and the vertebra should be ballooned out so that the height does not become less. Even if you leave them, they all recover without any serious treatment. Similarly, the patient says the pain is worse when patient is lying down. Lying down position, pain and burning. These are all very typical of esophageal pains. The esophageal pains, which we call as hyperacidity. Normally, esophagus empties into stomach, but there is a sphincter there. So the acid in the stomach cannot come up in the esophagus. As you grow old, a number of conditions, including tension, smoking, tobacco, gutka, tea, coffee, soft drinks, alcohol, liquor, chilies in the food, all of them increase this acidity. When this acidity increases, it goes up. So really speaking, this is esophageal pain, burning. And this comes mainly often after dinner and when the patient lies down on the bed. That position, that will give you indication that is esophagitis. And this sphincter which I told you, which is like a door, becomes loose as the age increases. With the result that old people, it again is very loose. Very loose. So with the result that esophagitis is very common in old people, elderly people. Very often you will find these patients, elderly patients, where they have chest pains. The cardiologist is consulted, he says there are heart pains. He has got multiple blocks, the elderly person. But then a gastroenterologist is consulted, he says these are esophageal pains. So often they will come back to you, you are their GP, you are their God. They will ask you, but you tell me, is it heart pains at night when he gets, or are it esophageal pains? Remember one thing, these elderly people, many of them can have both. Why are you thinking of one illness? He can have coronary blocks, he is 75 years old. He can have the esophageal hiatus is very loose. So when he lies down, he gets esophageal pain. So you tell the patient that you have got both. And if it is both, and then if you want to treat esophageal pain in such a patient, only giving proton pump inhibitors, antacid is not enough. That patient you should raise the head end of the patient by 10 inches. Whole night patient should sleep like this. Then only the esophageal pains will disappear. So continue the pain of angina, continue proton pump inhibitors, etc. But give this position and you will find the esophageal pains will disappear. Or become much less. Or they become much less. Now, by the way, about herpes, I wanted to tell you that in a chest patient, heart diagnosis is very commonly mistaken because the pain is very severe in this patient before the rash appears. But herpes can appear and can affect any part of the body. The pain can come here, severe. You might think of cholecystitis, gallstones, etc. And then second day, third day you find the rash appearing. So it can affect this area, severe pain here, severe pain here, severe pain, any part of the body, limbs, severe pain. Important thing is learn to see these vesicles. Learn to see them. They can come after 2 days or 3 days, but they start with second, third day. Once you can see them, that patient is going to develop herpes zoster. And I want to tell you something more. Herpes zoster incidence increases after old age. You see, we all have got this virus of herpes zoster in the body. It comes up when your immunity is less. So as you grow old, immunity is less. So in older people, herpes zoster more common. Very old people, very common. Now you can imagine at this old age to suffer from severe pain. If you want to prevent it, there is one thing which you can do as a GP. Give them a vaccination against herpes zoster. It is now available. Just like you give them vaccination for pneumonia, you give them vaccination for herpes zoster. All people more than 60 should receive herpes zoster vaccination. Now, coming to another cause of chest pain, psychogenic chest pain. It's a very common condition. These patients, you have no responsibility. They have gone to cardiologists. Cardiologists have told them they have no heart problem. Again they come back to you that I get pain in the heart, pain in the heart. It becomes actually it's a panic symptom. Then they develop panic symptoms. Then you have to treat it as a panic with drugs which you give for panic. These patients will not respond to anything unless you convince them that they are not heart pain. How will you convince them that they are not heart pains? The only method to convince them is called ambulatory Holter 24 hours ambulatory Holter ECG monitoring. Now, patient is not to be sent to the hospital. No admission is required. You only write down 24 hours ambulatory monitoring, and when the patient gets pain, that is the time you are looking at the ECG. ECG is absolutely normal. So then that is confirms that this pain is not due to ischemic heart, even if he has got mild ischemic heart. When he gets pain, severe pain, the ECG must show changes. So, therefore, in private practice, this is a very important investigation for your panic patients who are a headache to you, who go on complaining of pain, then pain in the chest, don't become better. And finally, yes, if a patient comes to you and you miss myocardial infarction, it's dangerous for your practice. It's bad. And you should not miss myocardial infarction. And nowadays you've got enzymes, for example, in the blood. Troponins are raised so high and all. You can diagnose. Number of methods of diagnosing. And I must tell you about this one patient of mine. She was a 56-year-old lady, fat lady. One day she developed severe epigastric pain. Severe epigastric pain. She vomited, she sweated. So the specialist came. He said, gallstones, biliary colic. He was right. Sonography was done and gallstones were seen. So immediately rang up the surgeon, operation was fixed up. The anesthetist pre-operatively did the ECG and found inferior wall myocardial infarction. This was a case of myocardial infarction and not gallstones. See, although both of them can cause severe epigastric pain. So if I see a patient of severe epigastric pain and vomiting, and if I have to send him for two investigations, either sonography or ECG, I will first send him for ECG. Because if he has got an inferior wall myocardial infarction, he needs to be hospitalized, ICU, immediate ascent. He could die. While if he has got cholecystitis, all he will do is later on he will become worse and he will need a surgery. So, very important differential diagnosis of inferior wall myocardial infarction, where the pain is in the epigastrium, not in the chest, But as usual, with severe pain, there is severe sweating out of proportion and vomiting. That much about the chest pain. Thank you.